Okay, good evening, everyone. Thank you for joining us this Wednesday evening on the FRCS Mentor Teaching Program. Tonight we have the presenter is Farid. He is an orthopedic surgeon from Bournemouth, and he's gonna tell us about adult hip reconstruction. Obviously, this is a massive topic, and he's gonna keep it, as we always try to do, FRCS focused. With us also other members of the mentor faculty, Amjad, Abdullah, and Sahib. So welcome everyone. Please, again, just to remind you, the teaching will be recorded and posted on the FRCS Mentor YouTube channel later on. And if anyone would like a CPT certificate, please contact me. Questions are always welcome. So please raise the hand symbol next to your name or post a question on the chat box, and we'll try to answer it to the best of our knowledge. And after this session, there will be a Viva and clinical session run by the mentors. So anyone who's interested, please let us know as soon as possible. It's first come, first served basis. So over to Farid now to start the teaching.
All right, thank you very much, Firas, and welcome everybody. So my name is Farid, as Firas has mentioned. I'm working as a hip and trauma surgeon in Poole and Bournemouth. So this presentation is just purely focused on the FRCS exam scenarios and teaching related to the FRCS, the thing they ask, the thing they want you to say. You may know a lot more about hip reconstruction, but we'll just focus it on to the exam-based things. So first of all, when we are dealing with adult hip reconstruction, hip osteoarthritis is the main thing which everyone should know. They will not expect you to know each and every details of a revision hip surgery, but they will expect you to know each and every details of the primary hip replacement, how they're gonna do, which approach you're gonna use, which component you should know, NGR statistics of that components, and why you are using it, and what is the mechanism of action. Recently, they have been asking a lot about metal on metal since Andy Murray had that done. So I think that's a hot topic these days. So everyone should be knowing in and out of the metal on metal. Avascular necrosis can be asked into the into your basic science or into adult pathology as well. Adult DDH is a very common thing that can be asked into long case or in the Viva. Acetabular or femoral loosening, aseptic loosening or septic loosening, this is common thing. If there's a massive defect, if you see any Viva, you just need to use your high order thinking. They are not asking you to describe how you're gonna fix it, but they will be asking you, a safest surgeon, as a first day DGH surgeon, how you're gonna do and how you're gonna approach on that. Pathological lesion in the proximal femur, that can be asked. Again, just keep things simple. Paget disease and ankylosing spondylitis are the common scenario. You need to look for, if they show you any X-rays of the pelvis, which have osteoarthritis, but it can be a Paget disease or it can be ankylosing spondylitis. You need to look for the clues. If there is any pubic synthesis of being used, or a lot of bamboo spine, some spine is visible onto the lumbar spine, then you need to just sometimes use these hints that may well be ankylosing spondylitis patient. Hip arthrodesis can come in the clinical or they can show you in the Viva. We're going to concentrate on the osteoarthritis of the hip. Now, it can be the long case, or they can show you X-rays on the simple. This is a very, very common thing you should know. Again, if it is coming in your clinical scenario, you need to spend a lot of time on history. A lot of mean you need to have a thorough history because that is the time where you can score really high. You're going to ask about pain. Again, where is the pain? Radiation of the pain, all the points which you have been learning into medical school is going to come there. Assess all the function and Oxford hip score, what the patient expectations are, any past medical history, including any history in the past, any clicky hips. I had a patient who was 45-year-old complaining of hip pain. And the moment I asked that since when she was having pain, it went back to that she had a congenital problem, was treated into a hip spike and things. Again, social history is important, drug history, allergic history. So keep things simple as your medical school. Don't miss anything because all of these things have points in there. Again, clinical examination. So clinical examination going to start from the moment you enter there. So keep your eyes open. Look for any clues. Look if there is any stick there, Zimmer frame there, shoe raise. Patient has a shoe raise or build up shoes in there. Look from the front. Ask them to undress. Comment on to the when the patients are getting undressed, whether they are getting difficulty in putting their trouser down. So you need to comment on that because the examiner is going to be looking into that, what you are looking at. Then from the front, you need to look at the any wasting of the quadriceps muscles. Look from the back, look for any spine curvature. Ask them to walk. Comment on the whether it's antalgic gait, Trendelenburg gait. Leg length, again, how the patient is standing. You need to examine the leg length while on the supine. You can comment when the patient is standing because the short leg, the long leg will be bent and flexed at the knee to compensate for the leg length problem. Fixed fraction deformity, always assess before commenting on the leg length, range of movement and neurovascular examination. Again, investigations, keep things simple. X-rays, they're going to show you the moment you say something, what you are suspecting, they're going to show you the X-rays. Now, we're going to discuss in last few slides how you're going to interpret all the X-rays. And depending upon the X-rays, you're going to go for the relevant investigations. Just make sure that don't say anything silly because this is not your registrar exam, this is your consultant exam. So all the investigation you're going to say should make sense and should lead to your either diagnosis or should lead to your management plan. So just keep things simple. Now, how are you going to manage the osteoarthritis of the hip? There are many options. I'm going to discuss in detail about the osteoarthritis of the hip, how you're going to reconstruct that primary hip replacement. So there are many options. You can have a uncemented total hip replacement, cemented total hip replacement, hybrid, or a hip resurfacing. Now, if you see the recent NGR 15 report, is the hybrid are going up and uncemented are going down. So cemented are going down. So again, what are the aim for the hip reconstruction? This is very, very important. You should know the principle. Either you are doing a primary hip replacement or doing a revision hip replacement. As long as you keep these 4 aims and the principles of hip reconstruction straight, you will have a successful outcome. And this is very, very important for exam as well. So what your primary aim is to restore the center of rotation, restore leg length, and maintain offset and abductor tension and correct component positioning. So if you fulfill all these 4 aims, you're going to have a successful hip reconstruction, whether it's a primary or whether it's a revision hip surgery. Now, there are many ways to fix the implants. You can use a cement or you can uncemented component. So cement, again, how kind of cements are available? Basically, it's a polymethyl methacrylate. You need to know the composition of that. It has solid and liquid component. There's low viscosity cement as well. Whatever you use, just say it. Sometimes they can show you, the Palaco cement and ask them what it is. You need to know the details, what is in there, how it's going to use, and where you're going to use it. Now, cementless, how this cementless is going to work? Basically, cementless relies on the biological fixation of the cement. They rely on bone ingrowth or bone on growth, depending upon what is on top of the component. So, bone ingrowth, you normally have a fiber mesh on there, and there is an optimal pore size should be 50 to 150 microgram for bone to ingrows, and they about 40 to 50% of the porosity. Now, these figures, they are not important for your Viva or clinicals, but they are important for your part 1. They're gonna they may ask you in the part 1 into the MCQs, but I don't think so. They're going to be concentrating more on these, very, very small things into the Viva or into the clinical scenario, but just for the Viva, for the written point of view, just bear that in mind. The gap should be minimal, less than 5 micrometer, 50 micrometer, and there should be initial rigid fixation. It can be line-to-line reaming. If you are doing line-to-line reaming, you need to use screws to fix it, to provide the initial rigid fixation, and then bone ingrowth can happen. If you are using press fit technique, then you need to ream at least 2 millimeter down. Some people do it 1 millimeter down. So if you are using a cementless acetabular component, you are putting, say, for example, a 50 cup in there, you need to ream up to 48 or 49 and then put 50 in there. It will cause the press fit at the rim, and if you are using it for the femoral component, then it will start the compression hoop stresses at the femoral shaft. There should be a good cortical bony contact. If it's relying on the cancellous bone, then you will have failure or the migration of the component. So you should have a cortical bone contact before for the bony ingrowth and for the success of the cementless component. And the viable bone, if there is a bone is not viable, irradiated bone, then there's less likely going to be bony ingrowth. So if you are putting your components into bone that has been irradiated, or there's a risk that you're going to have a radiation in future, then it's better to put some screws in there. Bone on growth, it depends again what is on top of that. Is the plasma spray. It basically is the blast surface with abrasive grit material. It's called grit blast fixation. Now, grit blast fixation is like a buzzword type thing. If they ask you how the bone is gonna get fixed, you're gonna say just grit blast fixation. If there is a plasma spray, it depends what component. Sometimes they show you an acetabular component. Just make sure that what is the surfaces look like, whether it's look like a fiber mesh or whether it's a plasma spray or whether it's a tabular metal, because all of these have different kind of, whether it's bone is going to ingrow or bone is going to outgrow. Now how the cemented stem works. So if you are using a cemented stem, then there are two basic principles or design of the stems. That is again very common. They can show you either a Charnley prosthesis or modern collarless polished taper stem, and they're going to ask you what it is, describe all the components of the stem, how it is going to work. Now, the composite beam design is an old design. It's based upon the Charnley low friction orthoplasty thing. It's a matte finish, and what it is, when you put this cement in and stem in, it's not polished stem and it's not tapered. So stem, cement, and the bone will act as a one unit. So there should be no movement at the cement and the stem level, but in reality there is some micro movement happens, and then that can cause loosening. Loaded taper design is a new technique that is Exeter and the CPT, which is the Zimmer Biomet stem. We use it, and that is a new design. So it uses the creep properties of the cement. So when you put the stem in, the cement will act as a grout, and with the passage of time, it will sink in about 1.6 millimeter in about a year's time. So they will ask you how this works. So that will use the creep property of the cement and will actually snug fit into the stem. If they show you Xrays, which has a CPT or Exeter or any colorless polished taper stem in there, if you see any loosening at the shoulder, that is very much normal, because that is where the stem is going to sink into the centralizer. If you see the centralizer, which is again made of polymethacrylate. It has a small gap in the end, which is about 1.4 to 1.6 millimeter, and that's where that stem is gonna sink in. So they did ask me in the exam, they did show me a CPT stem, asked me how this is gonna work, and then he showed me the X-rays where it has a slight, loosening, look like on the shoulder, and he asked me whether it's a loose or not. So it's not loose, it's always sinking, and that is how it works. Uncemented acetabulum. Now there are many. That is slightly history in there in this slide. There are about 3 generations. The first generation was, again, started from, people have tried all sort of things, from cylindrical, square, cones, ellipsoidal, and hemispherical. All these cups which we are using is a hemispherical cup. The second generation came in. The first generation was purely mechanical. So they were not thinking about the biological fixation in that time. They relied upon the screw fixation. They tried to screw the acetabulum into the pelvis. But now in the second generation, again, the aim for mechanical fixation along with biological fixation by adding some porous coating, and the concept of bone ingrowth came in. And the again requirements for the bone ingrowth were, it should be biocompatible, optimal pore site, and viable bone, and the initial stability. The third generation, which is again, is a tantalum tantalum. It's like a bone, act as a bone. It's very porous. It's a high porous component. It gives you a good initial rigid fixation, high coefficient of friction. It has been used in revision hip surgery. The tantalum can be used as augments as well, or a primary component of the acetabulum. Again, the modularity, the modularity gives you flexibility as well, but there's a risk of increased wear, especially on the backside wear, when there is a holes for the screw. You can have a lysis at that level. Again, it should be minimal thickness of the polyethylene. It should be 6 millimeter or more. If it's less than 6 millimeter, then it can have a catastrophic failure. Again, micromotion should be less than 28 micrometer. It can be fixed with the pegs, spikes, or screws. We use screws these days quite often. It has been shown that screws shows greater amount of bone ingrowth as compared to pegs and spikes, and biomechanical analysis show that screw helps convert torsion forces to the compression forces, and which increases the bone implant contact area. Cemented acetabular component, again, they can show you an X-rays, or they can show you a cemented acetabular component. You need to know how it works. Different parts of a cemented acetabular component. It's made of all polyethylene. There are many like metal-backed polyethylene as well, but again, they were high risk of failure. And cemented cup in revision surgery, so you can essentially cement a cup in the revision surgery, but again, just keep things simple to all polyethylene components. So that is again ideal ultra high molecular weight polyethylene acetabular component. Again, you need to know there's a flange at the end that will cause the compression of the cement. There are ports, straight grooves, undercut groove. So as long as you know all these components and can explain it, that's what it is. And that can be asked in the viva. They can show you a component and ask you in the viva. Revision hip replacements, what are the indication of the revision hip? How are you going to assess? What is the X-rays interpretation? And always bear that in mind, that when they show you any X-rays which has a massive defect, they are not asking you about how you're going to reconstruct that. What they are after is how you're going to work it up and how you're going to refer it, or whether you're going to refer it to, because you're never going to jump on doing a revision hip replacement as your first day consultant. What you're going to look at in the X-rays on the acetabulum side, you need to comment on the Charnley and Dilly zones, comment on the teardrop, Kohler's line, which is ischial and iliopectineal lines, how much is the ischial lysis is there, superior migration of the cup, and how much bone stock you have available. So that is what you're going to whenever they show you any X-rays, without saying the Peprosky classification, you need to comment on these. When you comment on these, you basically, what your Viva is a technique. So whenever you say these words, they're going to ask you, okay, how you classify it. If you say it's a Peprosky 3A, then they may not know, because most of them are not a revision hip surgeons. So what you need to go systematically, just comment on all these things. See where the acetabulum is loose, in which zone it is loose, whether the teardrop is visible, colar lines been breached or not breached, how much ischial osteolysis is there, and superior migration. Again, same is on the femur side. Again, I always ask for more views. If your only AP view is visible, just ask for lateral as well, because you may get surprised. I've seen femoral stem coming out of the femur on the lateral view, which was look slightly normal on AP views. So Gruen zones, comment on AP and lateral. Peprosky classification, we're going to discuss that, and mechanism of failure. So you need to give them a hint that what you're talking about. So mechanism of failure, like all the pistoning and mid-stem pivot and calcar, all these things. So you need to give them a hint so that they can, their next question comes, okay, how you classify the mechanism of failure. So again, that's a collarless polished taper stem. You need to know the different component. What is taper? What is the self-locking, self-releasing taper? What is the shoulder, and why is it collarless, and how it is made? Now you can, when they show you this stem, you have the ability to guide them where you want to take them, where you want your Viva to be guided to. You can take it to your biomaterials. You can tell them it's made of cobalt chrome, and then you can start describing the properties of the metals if you are good at it. But if you want to take it to the mechanism, then take it to the collarless polished taper stem mechanism, like it's a loaded taper stem, and they're going to take you to the other way. So you have the full ability to guide them into the Viva. So again, as I said, it's just a technique where you want to lead them. Don't lead them to your weak point. So acetabular bone defect. So Peprosky classification is mentioned. So type 1 is a minimal lysis. Basically, it all depends on whether you can get a primary stability of your trial component. In type 1 is a minimal lysis. You can just put a big cup and you will get a stable fixation. Type 2 is divided into 3 types, A, B, and C. Type A is the less than 2 centimeters superior migration. There will be no ischial osteolysis, and there will be only supromedial bone loss, but rim will be intact. You can still get away with the primary acetabular component. Type B is rim is intact, is the less than 2 centimeters superior migration. Now this migration is from your teardrop level, which is your floor of the acetabulum. It's a mainly supralateral bone loss, and type C is the medial bone loss. And the collar line, the bone loss is mainly medial to the collar line. But collar line is not going to be disrupted. I think they are all intact, but your lysis will be more medial. Then type 3 is again divided into 2. Now the primary component stability is not achieved. So how you gonna assess that? So when you are revising it, if you put the trial component in, and if you push it in, if it just flip over, it means it's not stable and you need to do something about it. And how you're gonna do it? You're gonna do a augment. So on the X-rays, how it's going to look like, there will be ischial osteolysis. Cochlear line will be intact in here, but there will be more than 2 centimeters superior migration, and it's mainly supralateral migration. And the host bone contact in a hemispherical cup will be less than 50%. In type B, the cochlear lines will be breached. There will be extensive bone lysis, or there may well be a pelvic discontinuity. So if you see that stage, now if you show you these X-rays, they are not, as I said, they're not going to ask you how you're going to reconstruct, but they will ask you how you're going to work it up, and you need to just give them a sensible answer. Femoral bone loss, again, is a Paprosky classification. You can use either, there are many classification, AOS or Paprosky. Whatever you use, just make sure you just know them in and out so that there's no confusion. Paprosky, again, depends upon whether you can get a primary stability or not. So first of all, you need to look at the metaphysis. If the metaphysis there's a minimal loss of metaphysis, but the whole of the diaphysis is intact, it means type 1. If there is a severe loss at the metaphysis, but the still diaphysis is intact or normal, it means you can have a distal fixation. So I guess type 2. Type 3 divided into two types, whether there is a more than 4 centimeter diaphysis intact. So what a whole point of this classification is whether you can get a distal fixation or not. So the distal fixation, if there is a more than 4 centimeter diaphysis intact, then you can essentially get a distal fixation and get away with the modular type stem. If there is less than 4 centimeter, but still there is some isthmus support, then you possibly can put the modular like a ZMR stem. But type 4, extensive metaphysis and diaphysis, so you need something like an interlock thing, which is locked on top and locked on bottom. So again, so just coming back to the basics, when you are in the clinicals, when any hip case come in or they ask you to take a viva, normally they give you a GP letter saying patient is this much of age, having pain since that much of duration. Start from basics, history, thorough history. Again, as I said, make sure ask since how long the pain is. Sometimes the pain goes back to childhood. Sometimes patient can have a septic hip, osteotomy in the past. So always take thorough history. Again, you look for clues. Listen to the examiners. Sometimes they just ask you to concentrate on to the leg length because they just want you to give a good examination of the leg length. How are you gonna measure the leg length? And it's a key thing if you are going for exam. Make sure practice this in your clinic. So even if you are in the fracture clinic, take the thorough history, presenting complaint, past medical history, drug history, social history, allergic history, all these things. Make it your habit. If it's not your habit, it's not going to come in the exam because in the exam you are quite tense anyway. So just keep it your habit and practice it and dictate it so that it just comes automatically like your routine habit. For viva, again, use your higher order thinking. So what it is, when they show you any X-rays, you need to know what the examiner want from you, and just listen to what he's saying. As I said previously, if they show you any extensive lysis or anything, then they're not gonna ask you about the reconstruction. They possibly ask you to work it up, whether it's a septic screen workup and whether aseptic loosening and why there is aseptic loosening. Keep it straightforward. Don't try to confuse, and again ask for that you're gonna always say that you're gonna refer it to a hip surgeon or revision hip surgeon, because and then they can say you, okay, you are the revision hip surgeon, then you can describe all the principles of a hip reconstruction. That's it really. I kept it quite straightforward for the exam point of view. Any questions?
Thank you, Farid, for taking on this topic. It's obviously a massive topic and difficult to cover everything about hip replacement. But I think that's what you presented is the most relevant points to tackle this question in the exam. So thank you very much, Farid. We appreciate your teaching and the effort you've put in to make up this presentation today. I just want to re-emphasize what Farid said. Stick to the basics. They're going to be high level of expectations from the candidates when it comes to hip replacements. Same like trauma. They expect you to know in and out of primary hip replacements. Yeah, it's one of the primary operations, one of the indicative operations. So you expect it to know all about it. But please don't jump straight away. Stick to the basics first and take it from there. See where the question is going. It depends also on which table you're sitting. So if you're sitting on a basic sciences table, expect more talk about biomaterials of hip components. If you're sitting on adult pathology, they might be wanting to talk to you about what hip replacement you do, complications of hip replacements, stuff like that. So judge it wherever you're sitting and listen to examiner, as Farid said, and take it from there. If they show you hip replacement in X-ray, don't jump straight away into whatever Exeter or Coral Pinnacle. Just take it step by step. Take questions step by step. Start by history, examination, investigations, always. Yeah. Otherwise, you lose easy points. And again, there are other presentations we've done on hips. You could find them on a channel. We've done hip stability. It was a session on hip stability and a session on periprosthetic hip fractures. So to complement this one. One of the other hot topics in related hot topics these days, which you need to know about to support your exam answer, is you need to know about ODEP, yeah, Orthopedic Data Evaluation Panel. We need to know about tranionosis, yeah, it's of course a hot topic these days, and also you need to know how to consent a patient for total hip replacement. This is very important, guys. Please make sure you revise all this before you go to exam. When it comes to revision, obviously you'll most likely would have done very well to go into revision. I don't think examiner would want to take you there. Either you taking them there with something you said, or you're doing very well. But also, if they take you there, just stick to the basic. They're not expecting you. If a case goes to a revision, that's not expected from you to jump into this. So you have to say, as Farid said, consult a senior colleague, yeah, when it comes to revision. And then when they tell you, okay, what's your opinion or what's your management plan, then that's when you start, taking, again, history, examination, cover the basics. If there's any loose hip, always think of infection, aseptic. Just go step by step in a logical way, systematic way. Don't just straight away go into the complex classifications, things like that. And when it comes to management, these classifications are very useful, but they're very complex. Exam purpose, what you need to know is you need basically to assess the bone stock. What you tell the examiner, I want to assess the bone stock. Do I need to reconstruct this, or can I work with the bone that I have, whether it's in the acetabular side or the femoral side? So do I need to reconstruct? If you need to reconstruct, then you actually need advanced skills in pelvic reconstruction and femoral replacement. Or can you work with the bones you have and use components like Farid said, trabecular metal components and stem distal fixation, revision stems. So that's basically what your answer should be focused on the how much bone stock you have, and can you use that to fix, or do you need to reconstruct? And just one question I have for Farid. One of the hot topics now in the orthopedic community in the UK now, which it might pop in the exam, is the girth. And
first time, isn't it?
Yes, and then there is a push towards cemented.
I think everyone will agree that whatsoever you are doing, just stick with that principle. It's the same as some people will say that centrolateral approach is better, less risk of dislocation. The people who has been trained in posterior approach, they will say that is excellent approach and there is no complication in their hand. So I will just say stick with the common things which you can defend in the exam. In your real life, whatever you do, stick with that. For the exam point of view, just make sure you stick, say for example, a hybrid hip replacement. The examiner is not going to guide you saying, do a cemented, what it is. They will ask you, what will you do? Your answer would be, I will use a hybrid total hip replacement. Just if you want to say CPT etiology, I did in my exam, I said CPT etiology. He said, why are you going to do this? And then my answer will be based upon ODEP rating, answer will be based upon NGR statistic, answer will be based upon my own experience, and I can support it, with the NGR statistics and can tell the the mechanism, how they work. So I think that's the key thing. Getting it right first time is, you cannot say, if I am trained to do a hybrid hip replacement, I cannot put a cemented cup in there because it's totally different science. And people who has been trained in cemented, I think they will struggle putting a hybrid, and the acetabulum uncemented in there. So I think we need to just keep things simple. For exam point of view, just prepare one thing which you're gonna get in the exam and get it done.
Thank you, Farid. Yeah, exactly. It's multifacets to this question, and yeah, just find what's best and justify your answer. We should be anyway in our daily practice doing what's best, and therefore we should be, able to justify that in the exam. We shouldn't be doing a prosthesis in our daily practice that's not the best. So all we need to do is just be able to justify it in the exam. But yeah, be aware of this GERFT. Before, there are some...
Best way to read is AAOS classification, which is very, very simple. So cavitatory and segmentary classification. And if you say to the examiner that I'll assess the bone stock as Frost said, I will assess the bone stock on the basis of the segmentary and cavitatory. If it is a cavitatory, I will look for the bone graft or the other trabecular metal to fill it up and to reconstruct the acetabulum, for example. And if it is segmental, I will have to arrange the cages and a bone graft to reconstruct the acetabulum, and to convert the segmentary into cavitatory, and then develop and build up the cavitatory with the cement or any other way of reconstructing it. So if you make it simple with the cavitatory and segmentary, they really can't go you beyond that, because that's actually is their limit as well.
Yeah, I like that, Saib. I think that's a good way of approaching it. Yeah,
that's true.
But I had this question in my exam, and goodness God, it was completely sort of Peprosky 3B sort of picture in the femur and Peprosky 2A in the acetabulum. But I simply just took it on its merit, because there was no much time left for me to actually, I could not progress it further from then on if I left it on the Peprosky. I simply said, it is segmentary defect. I will convert it to cavitatory using the cages, and then convert cavitatory into a normal acetabulum with the help of the bone graft, and that will get me out of it.
Good. One more question of Chanley, low friction arthroplasty. So obviously, that's the most first type of really successful, commercially successful hip replacement, and they always refer to as low friction arthroplasty. What does that mean?
So the low friction, what he did is the head size was 22.225 millimeter. You say that it was a low friction because of the smaller head size and trochanteric advancement. That was the whole concept of Chanley.
Yeah. So I agree with you. I think it's mainly the small head size. That's what I would say. Low friction because it's smaller head size. To the previously, they've been using hip replacements with a larger head size prior to that. But his concept was a small head diameter to reduce the friction. And that's basically what it is. I don't think there's any much more to it. I don't know if anyone knows different. Any of the other mentors know anything different? It's about the head size, isn't it, guys? Yeah.
Yeah, it is about the head size, the 22.225. That's the head he Charlie uses, and that's why he said it's now
But why is it called low friction? That's the question. Is it because of small head size? Yeah.
It's small head size. Yeah.
Three components in there. So one, he used to deepen the cup and fill it with the cement. He used to deepen the cup, small head size, and trochanteric advancement. There were three components to the Chanley replacement.
I think.
Thank you very much again to Farid for the nice presentation. Cover the topic very nicely. Thanks for the mentors, Sahib, Abdullah, and Amjad. We will finish this session today, this presentation session at the moment. Thank you everyone who attended. We have 79 people registered tonight. So thanks to everyone who attended. If anyone wants a CPD certificate, please get in touch with me in Telegram or Facebook. So I'll end this session now. And there will be a Viva session coming after that. Want to say?